Yes.
Thank you, Dr. Pereira. So it was written in 2016. It was revised actually. So today I will throw some lights on the developmental milestones. It always looks very easy, but believe me, they are not that easy, because when the question comes, uh, also like otherwise also as a clinician, we have to make sure that we are assessing the right developmental milestone, and we make sure that in each category they meet with the child, so that to address any delays. So I will start. So why it is important for us to know the milestones. So the clinicians should be aware of the developmental milestone for children, and especially areas of concern that may prompt referral of a child for further evaluation. Pediatric clinicians should carefully monitor the developmental progress in children born preterm. So what would be the objectives of today's lecture? It should be like discuss progress in typical developmental in motor, language, social, and cognitive domains. And I will throw light on each of them separately. Then note differences in the development for child who are born preterm, and then identify the delays that warrant referral for further evaluation. Why this is so important? The first years of development are crucial for lifelong learning and development. Milestones follow predictable courses in infants and children, and later developmental skills build on previous ones achieved. Understanding normal development can help clinicians to recognize delayed development. Early identification of developmental delays allows for referral to therapeutic services, and the children referred for early intervention are more likely to make gains in developmental milestones. Research into outcomes of intervening early in a child's life has shown a great variety of benefits when a child receives needed speech and language therapy, physical therapy, occupational therapy, or special education services in a language-rich preschool classroom environment. So this is very important, as we can see that we can just put in we can put the therapies in at right time so that we can actually address all those concerns. So coordination of these services is often provided by state-based early intervention programs, and these services may also be found in healthcare settings or departments of education. Targeted early intervention services may provide particular benefit for children living in families with access to few resources or lower educational status. So these are the benefits that we can get if we apply the early childhood intervention in proper time. So educational and cognitive outcomes, it can increase in intellectual competence, positive homeschool relationships, increase parental involvement in a child's schooling. It can improve literacy. It can improve school achievement. There would be less need for remedial assistance, less school failure, high school completion rates. Behavioral outcomes and the benefits in that domain is improved school readiness, reduction in juvenile delinquency, increase in child school engagement, less disruptive behavior in classroom, improved parent-child relationships, reduced participation in criminal activity. What would be the health outcomes? That would be earlier identification of children at risk, improved knowledge of nutrition, increase in medical checkups, decrease in illicit and illicit drug use, improved prenatal care, and fewer emergency department visits. What would be the economic outcomes? It would be improved living conditions, improved work skills, increase in family income, increased employment rates, decrease in welfare dependence. What would be the social outcomes? It would be decrease in teen pregnancies, reduction in child abuse, elimination of infant and child homicide, development of social support networks, increased familiarity with local healthcare social service support system, improved peer relationships, reduced social isolation, improved networks of support, improved network of support. Then other positive outcomes would be improved parent-child relationships, increased self-respect, acceptance of personal responsibility, and mental health benefits, environment with reduced stress, self-efficacy, lower rates of family adversity and conflict. Surveillance and screening. We all are pretty much aware of this in the clinic setting. We always do proper screening, surveillance at the right time. So what is surveillance? Surveillance is attentiveness to population trends in diseases, and screening involves administration of specific assessment to detect disease or disorder in individual children at a period when intervention would improve the developmental trajectories. Screening is not intended for diagnosis. So this is a very important point, that it's not intended for diagnosis, but rather for more rapid identification of individuals who require further evaluation. Children identified by a screening as positive for a particular disorder can be referred for further evaluation, which usually entails more comprehensive history, testing, and examination to elucidate diagnosis more clearly. What are the tools for screening? We are very much aware of this. So there are various valid tools that are available for standardized screening of childhood disorders and concerns. The American Academy of Pediatrics recommend that clinicians screen children for general development using standardized validated tools at 9 months, 18 months, 24 and 30 months, and for autism at 18 and 24 months, or at any point when a caregiver or the clinician has a concern. Clinicians should use a tool such as those recommended by AAP for screening children at the routine intervals during health supervision. So we all know that we have AMCHAT, which we do at certain months, and then we have ASQ, which we also do at 9, 18, 24, 30 months in the clinic. This is another, I just wanted to just throw a little light on it. This is called Denver's Developmental Screening Test. This is the only one we don't do it because it's more like in the neurology setting, but I found it very interesting. So that's why I just added it today. This is the Denver screening, and it has all the milestones in all the different domains. And we can see here gross motor, language, fine motor, and personal social. And how they do it, they just plot a line wherever the child is. Like it's here, it says it's 3 years and some months. And then if he has achieved this milestone or not. So we just write pass, or fail. And then we judge that if this child needs screening or not.
Can I comment on the Denver for you?
Yes, Dr.
So the Denver screening is what we used to use when I was a resident.
Oh, okay.
It's extremely cumbersome. It's very hard to give because you need like 40 to 60 minutes to give it. And if you have been in clinic at all, that's an impossible task.
Mm-hmm.
It became more of a test done by developmental specialists. But actually, if you look at the specificity and sensitivity of doing the Denver by the primary care doctor or doing the ASQ performs so much better. So actually, the ASQ, in my own experience, having been through both, I actually used to teach the Denver to residents since when I came here since 2007 to probably like 2012. And after that, the ASQ came in, and it's definitely a much better tool. And we pick up things better because it is so cumbersome, and it has a different outcome when we do it than when it's done by a developmental specialist in the right setting, and someone who can take an hour and a half to do such a test. Okay, go ahead.
Thank you, Dr. I will start with the developmental milestones. I will start with gradually with every, I will throw light in every month and then years. I know it would be a little time taken, but I wanted to just discuss it. And if I'm lacking something, just put your input so that we all should have some time to see the normal developmental milestones. So that would be more aware of these when we go to the clinic and we see the child, and we would be like, it would be just I would say a revision for us. So I will start with the neonatal period. The 4 weeks after birth set the stage for the infant's first year. Parents are learning to care for their infant, and early patterns of feeding, sleeping, and alert times are set. Infant learn to look at the faces, discriminate parents' voices from others, cry, makes noises with their throats, and raise their chins when prone. During this time, as well as prenatally, infants hear their parents' voices, beginning the attachment process. Infants are learning that their caregivers meet their needs, initiating a sense of security in these early days. All infants should receive hearing screenings in the neonatal period. So this is the first ever screening we do in the screening tools that we on the neonate. And older infants or young children who do not alert to sounds or visually fixate on objects within a few inches of their face should be referred for further hearing and vision assessment. Infants whose muscle tone is too low to allow for adequate feeding or movement should be referred for evaluation. So we got 3 so far. We got hearing, we got vision, and we got motor muscle tone evaluation. And I always remember when I am with Dr. Mendes, she always makes sure the fine motor, and she actually taught me how to assess the motor and just like stepping the child. And even if it's a neonatal, we do it on every neonate. So neonatal protective reflexes are a useful way for the clinicians to assess neurologic and motor functions. So also the reflexes, protective reflexes, we also get an idea. So let's move on to 2 months. The major milestone of 6 weeks in the social smile is the social smile, further endearing the infant to the parents. Around 2 months of age, infants coo and make noises responsively to caregivers. At this age, infants can bring their hands together at the midline. And when in a prone position, infants begin to lift their chests off the table at 2 months. But they may still exhibit head bobbing when supported in a seated position. So we do like more like the noises and the motor. Like we try to make them sit, and then we see some head bobbing, and also in the prone position, we check them. At the 4 months, by 4 months of age, head leg disappears. So if we try to make them sit while holding their both hands, we will see that their head leg disappears when infants are pulled to sitting. So the infant is learning to roll from prone to supine position. However, because of the current recommendation that all infants be put to sleep on their backs to prevent sudden infant death syndrome, rolling from front to back is sometimes delayed. Occasionally, infants learn to roll back to front first, despite it being generally easier to roll prone to supine. Infants at this age can reach for objects consistently, put them in their mouths, and shake or rattle. Interaction with others blossoms, and infants laugh out loud. So they can hold something in the object-wise, because it's the questions they're going to ask. And then they always put in MCQs 2, 4, 6. And then there's a point that we get a little confused because the answers are so close. So that's why we have to just pay attention to this. 6 months. From 5 to 6 months of age, infants learn to roll supine to prone and sit with hands propped in front of them. They can sit upright for a brief time, and when sitting is supported, they can use their hands to transfer an object from one hand to the other. So I will repeat, transfer an object from one hand to the other in 6 months. They reach for objects and can hold 2 objects simultaneously. Infants begin to feed themselves easy food, such as crackers, may hold a bottle. At this age, children move from cooing, which is using vowel sounds such as ah and oo, to babbling, using consonants, to making duplicating noises with sounds such as ba, ma, and da. And they smile and make noises in front of a mirror. At this age, infants begin stranger anxiety. So very important, I'll repeat. Stranger anxiety is 6 months. 6 months old infants are more likely to be wary of strangers and be comforted by familiar caregivers. 9 months. Around 9 months of age, children pull to stand and may begin creeping or cruising. Infants can play with toys from their seated position and take objects in and out of the containers. So this was also, if you, there was a question in ITE, so it also include 9 months, we remember 12 months and 15 months. So we will see that what was it. So objects in and out of the containers. So like if a small cube, they will put it in the container and take it out. Bang toys or blocks together and hold food to take bites. Oh, sorry, I shouldn't. At this age, gaze monitoring are interested in what others around them find interesting and are eager to engage. These infants respond to simple commands and may begin using dada, papa, mama, non-specifically in babble. 12 months. The 1-year-old mark hails numerous changes in a child's life. So children begin to walk and talk around this age. Increased communication and mobility have cascading effects for learning in all domains. By 12 months, many infants can stand well with legs apart and arms out or overhead. They can walk either independently or while holding the hand of a caregiver. They have learned to throw objects and can enjoy the wonders of gravity by dropping objects over the side of the high chair or stroller. 1-year-olds cooperate with dressing, remove hats and socks, and finger feed themselves using a mature pincer grasp. So 12 months, pincer grasp. They look for hidden toys and can let adults know when they need help. Proto-imperative pointing involves pointing to obtain a desired object, an action that becomes very useful for emerging toddlers discovering their own wishes. These children understand and respond to no, even if they don't always obey. They begin using words. 15 months. As children pass their first birthday, many new skills continue to emerge. Early toddlers are beginning to learn more words. Many combine babbling, jargon, or words for a delightful language of all their own. The children begin to point to body parts or objects in books upon request and retrieve an object when sent. For example, when they ask to go to their shoes, so they will be ready to go to the park, they will go and get their shoes. In addition, they can turn pages in a book, which is important for early reading development. And they can place 10 cubes in a cup. So don't confuse cubes with the blocks. Blocks are different. The cubes are very small. So they can put 10 cubes in a cup, a palette in a small bottle, and a circle in a shape puzzle. A key skill by this age is proto-declarative pointing or pointing to express interest. 15-month-olds scribble on paper with a crayon and build a 3-cube tower. So 15 months can build a 3-block tower. Just remember this. And then at this age, empathy begins to develop and children can feel happy or sad alongside a peer or family member. So they can have emotions developing. So they can be sad, they can be happy, they can also feel sorry. 18 months. At 18 months of age, children can run, seat themselves in a chair, make a 4-cube tower. So 15 months is a 3-block tower. At 18 months, it's a 4-block. And imitate vertical strokes with a crayon. They pretend to talk on a phone, drive a car, or have a tea party. Children now begin to understand the concept of mine. And this often becomes a favorite word as the children learn possessiveness. Shame, guilt, or sadness, or after wrongdoing emerge at this age. This is also very, very important. Shame, guilt, or sadness after wrongdoing emerge at 18 months and may affect a child's choice of action. Children at 18 months often use 10 to 25 words or more and point to pictures, people, and body parts, as well as name a familiar object when requested. 24 months. Here begins the wonderful world of a 2-year-old. Children who are 24 months can kick a ball, throw overhand, and begin to learn to jump. They can imitate circles and horizontal lines. They are beginning to take clothes off independently, a key step to potty training, and can turn doorknobs. Socially, they often play in parallel, side by side. This is also very important. So side by side is 24 months, but often without significant cooperation. They can demonstrate defiant behavior as well as mask certain feelings when socially appropriate. At 2 years of age, children are using between 50 to 200 words, putting 2 words together in a sentence with a noun and verb and calling themselves by name. 36 months, 3 years, is the magical year of pretend play, socialization, developing creativity. By 3 years, most children can identify their own gender as well as the gender of their friends. Children learn to draw a circle, are able to climb on a jungle gym and run much more quicker than before. Sentences develop into paragraphs and children begin to take part in back and forth conversation. A 3-year-old can fear imaginary things and describe what others might be thinking. So identifying of gender is very important and it happens at 36 months. 4 years. At 4 years, children are gaining greater balances and learn to hop on one foot a few times in a row. They can balance on each foot for 4 to 8 seconds, jump 1 to 2 feet forward and gallop. 4-year-old can learn to copy a cross and a square with a crayon. So 3 years, a circle, and 4 year is a cross and a square. Tie a knot and cut papers. So this is also age of preschooling. 4 years old can also draw a 4 to 6 part person. They can point to 5 to 6 colors, identify many numbers, letters, count to 4 by rote, possibly recognize signs such as stop sign or favorite stores or brands. They are able to use the restroom independently. They brush their teeth, wash hands, face, and use a fork. During the year 4 years, often develop a preference for certain friends, and can identify emotions they may feel, and are learning to play in groups. 5 years. At the 5-year birthday, children enter the school age years. Their balance improves to more than 8 seconds per foot. They can hop on one foot for 15 times in a row. They can learn to skip. They can copy a triangle, cut out shapes with scissors, write their names, and use blocks to build stairs. They can dress themselves in the morning and are often able to bath independently. Children draw a person with 8 to 10 parts, identify coins, recite the alphabet, and count out loud. At this age, children sometimes skip letters or give numbers out of orders. They may still write some letters and numbers reverse. The ability to hear and produce rhyming words is an important predictor of early phonemic awareness and literacy skills. By the end of kindergarten, children usually know the sounds that consonants and short vowels make and can often read 25 words or more. So they start reading. Socially, children in kindergarten usually have a group of friends and are able to be glad for their friends when good thing happens. During this year, children learn right from left from their own perspective and can identify locations. At this age, children have more than 2,000 words and can define simple words, use sentences competently and memorize their telephone numbers or addresses. They can answer why questions, and children often love to be read to and can repeat stories. Retelling the beginning, middle, and the end of the plot, creativity and unique interests begin to emerge in this delightful age. 6 to 12 years. The school years are devoted to gaining and refining skills. Children develop greater motor skills and proceed from learning to run, hop, and skip to more complex skills, such as soccer, swimming, or dancing. By 6 years, many children have mastered riding a bicycle without training wheels. Fine motor progresses to improved handwriting, and then more complex tasks such as fingering on the violin, drawing, painting, woodworking, typing. Children are able to speak in paragraphs, hold conversations, recount stories with detail. Around the 3rd grade, children progress from learning to read and begin reading to learn, thus opening a world of knowledge. And the elementary years are an enjoyable time of learning, growing, and exploring. So this, I would recommend you to go. There is a very comprehensive tables, and it have all the gross motors, fine motors, self-help, problem solving, social, economical, receptive language, expressive language, and it has all the months individually. I just wanted to show you. Each and every month have their own, and they have just put it in points so that you can remember. So, and I can assure you will be getting a lot of questions. We will be getting a lot of questions in this block test from this table only. So this is these are just, so I will just like to throw some red flags, developmental red flags. The neonatal period, the red flags are, what are the red flags in neonatal period in language and cognitive domains? It's that infant does not respond to loud sounds, or muscle tone too low to feed, or caregiver shows indifference or social economically, a caregiver shows indifference or disinterest in infant. What are the red flags in 2 months? That it does not alert to voice, they cannot raise their head when prone, and lack of looking at faces. 4 months, no cooing or gurgling sounds, unable to bring hands to midline, and lack of smiling. 6 months, lack of turning toward voices, does not pass objects from one hand to another, no smiling, laughing, or expression. 9 months, lack of babbling with consonants, inability to sit, lack of rolling, absence of back and forth smiles and vocalization in conversation. At 12 months, child does not respond to names, does not understand no, does not stand or bear weights on legs when supported, it's motor, and indifferent or resistant attachment to caregiver, does not look where caregiver points. 15 months, does not use words such as mama and papa and dada, no pincer grasps, absence of motor, proto-imperative pointing, which is point to desired objects. 18 months, he's not using at least 6 words, in his inability to walk independently, or absence of point to show interest or show gestures. 24 months, lack of words or 2 words, meaningful sentences, inability to follow simple commands, inability to walk well, does not imitate actions or words of caregivers, poor eye contact. At 36 months, inability to use 3-word sentences, frequent falling or difficulty with stairs, lack of pretend play. 4 years, unclear speech, does not answer simple question, inability to use pronouns. does not jump in place, ignore other children. 5 years, inability to rhyme, inability to recognize shapes, letters, colors, resist dressing, sleeping, using the toilet, does not draw pictures or a square or a cross, poor balance, unusually fearful, sad, shy, angry, does not distinguish between real and make-believe. 6 to 12 years, cannot retell or summarize a story with the beginning, middle, and end, does not skip or hop on one foot, does not write his name, does not name friends, cannot recognize feelings in others. At any age, loss of previously acquired skill. Preterm screening. So this was the developmental milestones and the red flags in a child who was born full term. So I will just discuss a little bit about the preterm screening. If a child is born preterm. On the basis of the observational studies, preterm birth is a leading cause of neurodevelopmental disabilities in children. And the degree of neurodevelopmental disability is inversely correlated with the gestational age at birth. So when comparing performance of preterm children to developmental norms, corrected age or age from due date rather than birth date should be used for first 24 to 36 months. So I will repeat myself to make it more clear that we correct the gestational age. We have a chart. If we go to Athena, we have a chart in which we correct the age first. We also do it for the vitals, and we should always do it for the milestones too, that we correct the age of the child and we do it till first 24 to 36 months if he's born preterm. On the basis of observational studies, clinicians should pay specific attention to sensory function in children born preterm because an incidence of visual and hearing impairments is higher in preterm than term children. Due to the elevated risk of cognitive and behavioral disabilities, clinicians caring for children born preterm should be vigilant when performing developmental assessments to improve outcomes. On the basis of observational studies, early identification of developmental delays allows for referral to therapeutic services, and children referred for early intervention are more likely to make gains in developmental milestones. So with the preterm, we have to make even more attention. Risk factors for developmental behavioral concerns following preterm birth. What are the prenatal risk factors? That is very low birth weight, which is less than 1,500 grams, extremely low gestational age, which is less than 28 weeks of gestation, intrauterine growth rate restriction, or a male gender. What are the postnatal risk factors for developmental delays in a preterm? Neonatal seizures before 28 days of age, abnormal brain imaging, white matter injury, or periventricular leukomalacia, grade 3 or 4 intraventricular hemorrhage, chronic lung disease, bronchopulmonary dysplasia, prolonged mechanical ventilation more than 96 hours, bacteremia, meningitis, or sepsis, necrotizing enterocolitis, feeding problems beyond 36 weeks post-menstrual age, extracorporeal membrane oxygenation. Socially, low socioeconomic status, low parental education achievement, language barrier with family, or parental depression. What are the red flags in a preterm? When children are delayed beyond their corrected age, this is a red flag. Oh, sorry, also for the other one, the preterm and for the regular full-term children. When children are delayed beyond their corrected age, this is a red flag for concern. Pediatric clinicians should be aware that correcting for gestational age may overcorrect for milestones in the social and language domains, and these may need closer attention. By age 2 or 3, most children with transient delays related to prematurity have caught up with their term peers, and chronological age can be used. This time point also corresponds to preschool entrance for many children, and because school entrance is based on chronological rather than corrected age, reverting to chronological age allows the provision of appropriate services for preterm children cared for alongside their term peers. Language delays are more common in infants which are born preterm due to distinct or compounded difficulties with processing auditory or visual information, learning and conceptualizing verbal language, and producing speech sound. As they reach school age, children born preterm are at particular risk for learning delays, both those related to spoken or written language production and those related to behavioral problems that make classroom learning challenges. Both externalizing and internalizing behavior as well as social difficulties are more common in preterm than term children. Due to the elevated risk of sometimes subtle cognitive or behavioral disabilities, pediatric clinicians caring for children born preterm must be particularly vigilant when performing developmental assessments. So this ends my presentation. I have some questions. So let's discuss the questions. So what is the purpose of screening for developmental milestones? A is assess the incidence of developmental delays in a clinical population. B, it diagnose the developmental delays. C, it's identify children for referral to special education programs. D, it identify children who should be referred for further evaluation. Or E, it is a plan for treatment of developmental delays. What do you think? Anyone?
D. I think it's D.
Yes, that's correct. It's D, that, as I said, and I repeated myself because I knew that also, but also it's important for us to know that identify children who should be referred for further evaluation, because the diagnosis is up to the developmental pediatrician. We just refer our concerns and we refer them for further evaluation to the specific specialities. A term 4 months old male infant is developing normally. Which of the following is the major milestones for normally developing child at this age?
C.
Bring hands together to the midline, lift head up when prone, no head lag when pulled to sit, D, social smile, or roll supine to prone.
C.
Who said D?
No, I said C.
C, yes, correct, C. So no head lag when pulled to sit is the milestone for a 4 months old. Good. Good, Peter. A child is able to run, make a 4-cube tower with blocks and have a tea party. She understands mine and she feels badly when she steps on her mother's foot. Given normal developmental progress, how old she is?
B. Boy.
Correct. 18 months. She says mine, 18. Mine, and she has the feeling of feeling sorry, and she can make 4-cube towers. So she's 18 months. B is correct. Thank you. 4, a 3-year-old is developing normally. Which of the following milestone is consistent with her developmental age? She can copy a square. She can identify her own gender. She can imitate a horizontal line. She can throw a ball overhand, or she can turn doorknobs. What do you think?
C. I'm not sure about C.
I think it's B.
It's B.
One, two, three.
All right, can other people also answer what they think? Let's not all be so quiet, okay? It's a learning experience.
I can hear you.
It is B, yes, correct. So they can identify their own gender at a 3 year of age. And the last
Can I
question.
say something? Can I say something about this question?
Yes, Dr. Mendes.
It is important that when you go, the first thing you do when you go into a 3-year-old's room is to ask them, what's your name? Or are you a boy or a girl? When they answer you, if they answer the wrong gender, don't try to correct them. Just ask them again. And if they say the wrong gender, do not tell them this is your gender. It's a very sensitive issue. Kids at 3 years of age know their gender, but some kids might start saying, will say another gender. So remember that one of the things that Shafia said is that part of doing all this developmental assessment is to remember that what we say to kids affects their self-esteem. Okay, so you don't treat parents bad in front of kids. You don't argue with kids about what they tell you. Being right in front of the family is not our goal. We have to be right when we take the test. So be incredibly sensitive. I don't care what we're used to. I don't care what our backgrounds are. I don't care what we believe. When you go into that room, it's about the patient. So if a 3-year-old tells you that he's a girl and he's a boy, don't argue with him. Just document that he said he was a girl. Okay, so be very sensitive to this. Extremely important. And the same thing with everything in development. Remember that every word that comes out of your mouth either destroys the self-esteem of the patient or increases it. You are an authority figure in front of that kid. Do not argue if they tell you the wrong sex, or if when you're asking questions about development, if they tell you the wrong answer. And don't keep probing, because the kid is not stupid and he will realize that something is wrong. Just do it, make it like a game, and come out and document it, okay?
So the last
ahead.
question and the last slide also. How long should you correct for gestational age when evaluating a preterm infant? 6 months, 12 months, 24 months until kindergarten, or until entry to the high school?
24 months.
24 months, yes, that's correct. And I was a little mischievous, I would say, because I kept on repeating whatever the answers were, just to, get you all people correct answers. But having said that, this question part is different. Being a clinicians, which we all will be, is a different thing. We have to make sure that developmental milestones should be met. If not, then we have to refer to the evaluation, which is the whole summary of this presentation. Thank you so much. Have a beautiful day. Bye.
Thank you, Shafia. That was
All right,
perfect.
so I just wanted to